Bismillahirrahmanirrahim. Assalamu alaikum. Another video station is presented with life-threatening asthma. So in the video, I can see there is 7 years old female girl in propped up position, hospital settings, well grown for her age. However, I want to do the anthropometry, and there is no dysmorphic feature. She is connected to oxygen device, and there is a monitor is attached, and she has respiratory distress in the form of she is tachypneic and use of accessory muscle of respiration, but I can appreciate any cyanosis, and there is audible which is present, and monitor shows that SpO2 is 44%, and there is tachycardia is present, and peak expiratory flow rate is 23%. So it's a case of life threatening asthma. My differential diagnosis: pneumonia, congestive cardiac failure, aspiration, foreign body, cystic fibrosis, diabetes ketoacidosis, and hyperventilation. So the history is onset if it is a case of asthma. So onset, course and duration, aggravating factor, relieving factor, any preceding illness present or not, any chest tightness, night symptoms, breathlessness, sinus, blue coloration present or not, and is there any allergic rhinitis, skin eczema present or not, and past history of such kind of illness, number of hospitalization and level of care, and how many GP visit, use of steroid, and family history of such illness, environmental home history, any patch, any carpeting present or not, any PCP smoking present or not. And then on examination, vital sign SpO2, consciousness level, cyanosis, skin eczema present or not, and local examination, respiratory system, air entry, and sign of respiratory distress. And then management, if it is a life-threatening asthma, so management, I will involve my consultant and PICU. I involve my senior and consultant, and then airway, breathing, circulation, oxygen inhalation, and then if the patient is in shock, so IV normal saline, and salbutamol nebulization, and by puff or continuous salbutamol, oxygen derived salbutamol nebulization. If then inhaled ipratropium bromide, IV hydrocortisone. If improved, then continuous nebulization, oxygen inhalation. If meets the discharge criteria, then discharge. But if it is not improved the condition, then IV salbutamol bolus, if not improved, IV magnesium bolus, and if not improved, then infusion salbutamol. While giving the IV salbutamol, we will monitor for heart rate and respiratory rate every 10 minutes, and we will do the electrolytes, urea electrolytes, and capillary blood gas for potassium. And if whenever we are giving the magnesium, in the salbutamol infusion, we have to check the heart rate and respiratory rate every 10 minutes. While in the magnesium IV bolus, we will monitor the heart rate, blood pressure, every and heart rate, blood pressure, and respiratory rate every 5 minutes. And ECG monitoring and carbon dioxide monitoring is needed in case. Here the ECG monitoring is needed in case of salbutamol IV bolus, but both salbutamol and magnesium we needed to monitor SpO2, carbon dioxide regularly, continuously. This is the acute management. And when we will do for chest X-ray, if severe life-threatening, no improvement with medical management. and now this is the acute management, and then chronic management or long-term management. Long-term management prescribe beta agonist with spacer less than 3 years with masks and more than 3 years without masks. Oral prednisolone 3 to 5 days, preventer if appropriate. And if it is life-threatening asthma, so follow-up refer to pediatric respiratory specialist, and and advice to GP after within 2 working days, and refer for if a smoker, refer for a smoker cessation service, identify the trigger, and chronic management action plan, support group, steroid cut if on high dose steroid. Discharge criteria: SpO2 more than in air more than 94%, stable vital sign, and peak expiratory flow rate is more than 75%, and stable 4-hourly management. And what are the features of life-threatening asthma? True irritability exerted through can't complete the sentence, and peak expiratory flow rate is less than 92%. Peak expiratory flow rate is less than less than or equal to 30%, and SpO2 less than 92%. Cyanosis pallor is present. What is severe acute asthma? This is T. T for true breathlessness to talk, tachypnea, tachycardia, and SpO2 less than or equal to 92%, and peak expiratory flow rate less than or equal to 50%. And mild is stable vital sign, mild wheeze, and can speak complete sentence, SpO2 more than 92%, and peak expiratory flow rate more than 50%. And another is salbutamol reducing regimen. So whenever discharge, 10 puff every 4 hourly, and for the next days 8 puff for every 6 hourly for 1 day, and then 6 puff every 8 hourly for 1 day, and 4 puff every 12 hourly for 1 day, and then 2 to 4 puff when required. Another topic is viral induced phase and multi-trigger phase. Viral induced phase is episodic phase, and risk factor who have bronchiolitis in the first year of life, and viral induced phase treatment is bronchodilator, montelukast. And multi-trigger phase, this follows the respiratory infection, also the triggers such as the exercise, exposure to allergen, smoke, and it's a part of atopic march, and 50% has chance to develop asthma. And here the risk factors are major criteria: family history and allergic atopic dermatitis, and minor criteria: allergic rhinitis, wheezing unrelated to cold, and blood eosinophilia more than 4%. And treatment is inhaled corticosteroid and or ligotine receptor antagonist, montelukast. Thank you. Assalamu alaikum.